Hello, and thanks for loading up the latest installment of the World Extreme Medicine podcast, a natural home for people with restless and adventurous minds. I'm your host, jobbing GP and WEM Medical Director, Will Duffin. As extreme medics, our involvement in expeditions normally begins long before anyone boards a plane to a remote corner of the planet. We're often involved upstream in assessing an individual's fitness and indeed aptitude for a given environment, weighing up pre-existing conditions, anticipating medical risks. And this can be a really tricky area. So to shed some light on this, I'm talking today to Dr. Kent Haworth, who is a consultant occupational medicine physician. He's passionate about occupational medicine and its application to maximum benefit in real-world working environments. Kent originally trained as a GP, a family physician, in 1998 before retraining in occupational medicine to pursue his interest in dive medicine. He went on to work as a GP and occupational physician in the British Army and the Royal Navy, gaining additional experience in aviation medicine in a military career spanning 29 years. And in addition to being an integral part of military operations, Kent's also provided medical cover for TV and film projects, including the Coldest Race on Earth with James Cracknell. And his expedition work has taken him to places like Egypt, Libya, Singapore, and Myanmar. Kent's just been out in Jeddah for the past 2 years, working at the King Abdullah University of Science and Technology, which is a private research university in Saudi Arabia. And he just moved back to the UK, living now in West Sussex. And Kent's just completed his 14-day mandatory quarantine period. So, Kent, welcome to Wemcast. And how does it feel to be free?
It feels wonderful to be free. Thank you very much for inviting me to join you today. It is great to be out of quarantine. Very necessary public health measure, of course. So very happy to comply with that fully. It has been a long 10 days. Being able to get out and about yesterday was a real boon. So I've got a week now before I start work again, and I'm going to try and make the most of it. Get as much fresh air in the cold and bright weather that we're seeing now in West Sussex. It's great.
Yeah, it's not nice being cooped up indoors, but you of all people understand the reasons why. So that's nice. And you've had a really interesting career, such breadth to what you've done. And as you know, World Extreme Medicine, a lot of our courses, we talk about evaluating participants and pre-existing conditions. And we just thought it would be great to have your insights as someone with real expertise in this area. We're really pleased to have you on the Wemcast. Now, the very specialty areas that you've kind of dabbled in over the years include diving, aviation, offshore, oil and gas, expeditions. What would be really helpful to start with, Kent, is could you give us just some core principles of how you as an occupational health physician approach evaluating someone pre-departure, pre-deployment? You know, what are the key parts of that encounter that you have with someone?
Absolutely. And just listening to your intro before, Will, you speak about the importance of preparation. And if I were to say anything about preparing or the preparatory phase of expeditions or any remote ventures or anything indeed where you're taken to outside of the immediate medical care system that we enjoy in the UK generally, it's all about preparation. Assessing somebody's suitability to work in any given environment it can be a real challenge. Now, of course, you're looking at specialty areas like diving or aviation, oil and gas. You benefit from having a rule book, a book of medical standards that you can refer to. And those areas in particular that I've spoken about have grown up as subspecialties within occupational medicine. And there are a number of very notable, very eminent physicians and other allied healthcare workers in those occupations who you can go to for a lot of advice and guidance. But it's in the areas where you may not enjoy a rule book, a book of medical standards, or where the environment that individuals are entering is not so mainstream. It's where the principles of occupational medicine really come in. And occupational medicine is a mainstream specialty. It's gaining greater and greater prominence both here and overseas. But it's all about the interface between work and health, and how work affects health and how health affects work in a positive, neutral, or unfortunately sometimes negative way. And it's understanding that interface and working towards mapping the individual to the workspace, or more properly, the workspace to the individual, making sure that there is a good fit there, and there are well-established means of trying to make that work where possible. That's where, if that's the underlying principle of preparing people to enter these these environments. You're looking at the really big area that one needs to consider in order to optimize the outcomes, both on a personal level or a collective level. Get to where you need to be. Really benefits from solid preparation in all areas. During the venture, the expedition, one always has to bear in mind that the risk assessment that forms part of the preparation can change. It's a dynamic situation. Leaders need to be able to react quickly to changing situations, and occupational medicine can help guide in making sense of the different hazards and risks identified. But also, I think, really importantly, this day and age, is the post phase. People who may have suffered injury, whether that's physical or psychological injury, doing whatever they're doing, reintegrating into their day job, so to speak, unless their mainstream is in the wilderness space. Reintegrating people into where they came from in terms of their working life is also really important. And sometimes I just get the sense that we don't pay enough attention to that.
So I can see what it would be like, say, doing a medical for a lorry driver. Let's say he's got obesity, he's got type 2 diabetes, he's going to be driving long haul with trucks across to mainland Europe. It's someone with pre-existing conditions, that's his environment. But what about an extreme environment? What are the unique considerations? So let's take the example of diving. I think that's a great place to start, because you're sending someone underwater under pressure, and lots can go wrong. Puts a lot of strain on our own physiology. What are the unique considerations when you prepare to allow someone to enter into that kind of environment? What are the main things that are going through your mind when you're doing, say, a dive medical?
Okay, so I think the first thing one needs to establish is what is the purpose of the reason for this person's diving activity, whether or not it's recreational, whether or not it is professional. So you have professional divers, or somewhere in between, which is the research or the scientific diving, which is what I was mainly involved in my immediate past employment. there are standards. So once you identify what group the individual falls into, one needs to identify the standards that should apply. In diving medicine, there are many different standards. They're all variations on a theme, but the thoroughness with which they are applied, the detail of how they're applied differs between organization and organization. And if one is pressing the quality agenda, and I would always suggest that that should always be first and foremost in our rationale, not to the extent of regulating to ad infinitum, where really there's very little movement, because there's always something that you depends on how hard you look. There's always something that you can identify that may present an obstacle, but it's using one's experience and training against the set of guidelines generally. I'm talking about the research environment here, and making sure that where there are good reasons for good reasons for making an unfit assessment on somebody, it's well founded in the evidence, and sometimes the evidence is a little bit difficult to its origin to ascertain, but most of the time it's fairly straightforward and accepted.
Well, Ken, can you give us an example of just a couple of common conditions that you've come across doing dive medicals that have led you to recommend that someone doesn't go ahead and dive? What kind of things are commonly come up?
Absolutely. And so, for instance, in the research diving area, there are the standards that we used in Jeddah were the American Academy of Underwater Sciences standards for research diving, and they require the individual, the diver, to be seen, assessed by a physician of their choice, preferably somebody who is trained in underwater medicine. And just thinking of one of the main reasons why we were unable to pass as fit a number of our divers was asthma, and it's very interesting in this day and age of COVID, whereby we found that we had some divers coming to for assessment who hitherto had never had a diving medical at all, who had been diving but had certainly not had a diving medical to the standards that that the university ascribed to. But one of the main problems that we found was in the assessment, the necessary level of assessment that of divers with a history of asthma, is that we simply couldn't access the type of assessment, so bronchial provocation tests in one, certainly in one area. It was just impossible to get hold of. So we're talking about preparation here, and if one of the recommendations that I made, which was pretty much all I could do in this situation, given that to apply the standards that I wanted to apply was impossible in where we were working, was to try and get these medicals done before people arrived in country, where it may or may not have been easier for them to access this test. So asthma is so common, and there are many divers with asthma, but it's being able to understand the individual's particular type of asthma, their level of control, and their understanding of their condition, and putting in place mitigations which would make it safer than somebody without asthma. So that's one very common example, which was frustrated by the COVID pandemic and the limited access to certain tests that were required to fully assess.
That must have been very difficult. What about ENT problems, Kent? Do they come up a lot? History of perforation, that kind of thing?
Yeah, well, one of the main one of the problems that we commonly see is people who want to start diving. So these would probably be mainly in the recreational area. Is an inability to clear one's ears to perform a Valsalva. If you can't do that, then it's going to be really, really difficult to train safely to dive, and it's one of those conditions whereby we generally say that it's not a great idea, that or diving is probably not for you until one can easily reliably clear their ears. Of course, there are temporary situations where clearing your ears, performing a Valsalva might be difficult, upper respiratory tract infections and so on. But if somebody who was, to all intents and purposes, was unable to clear their ears for anatomical reasons, then that would prescribe their fitness.
So there are these guidelines that you've mentioned, but you're also, it's all case by case basis by the sounds of it. So you're making quite a nuanced judgment in each instance. Is that right?
Yeah, I think there are some absolute contraindications, and we've spoken of at least one there. But where it is safe, or where there are mitigations, so you might think about limiting depth, you might think about other mitigations, that you try your best to screen people in, as opposed to screening out as a concept. But it is a challenge, and I think one needs to be really careful about knowing at least a working knowledge of diving medicine, if nothing else, to allow you to understand what you don't know. To know what you don't know, I think is really, really important, because if you recognize that, then you can seek relevant input, and that is something that I think is a key factor. Recognizing when you need help.
So that's really interesting to hear. So you need a knowledge of the condition in hand, and that's where your medical background comes in. But clearly you also need a knowledge of the environment and the activity that person's doing. So, to understand what the difference between recreational diving at, say, 18 meters compared to deep diving on different gas mixtures, much higher levels of risk, the risk of decompression illness, having to do deco stops, that kind of thing. So, where were you able to gain that knowledge of the environment that enabled you to then make those recommendations on what mitigating measures, what depths, etc., that would make that activity safe?
Yeah, so that diving medicine was one of my interest in diving medicine was one of the main reasons I went into occupational medicine. In answer to your question, I think if you are interested in that environment, well, start getting involved in that environment. So start by learning to dive, and there are many ways that you can do that. But also, if you're developing an interest in diving medicine, there is a number of really, really interesting, relatively affordable means of developing expertise, accreditation in diving medicine. I was very lucky to have, during my time in the Royal Navy, to have worked in the diving medicine division. So we not only delivered diving medicine courses, but we got involved in assessing fitness and treating stricken divers in in the hyperbaric chambers that were at close to where we were in Gosport, and then they moved over to Chichester. But I was also very lucky recently when I was in Jeddah to be able to go to Fremantle in Western Australia to undergo an equivalent course there, in part to keep on top of my working knowledge of diving medicine, but also to immerse yourself in the continuing professional development in that word. And I would really encourage anybody with an interest in this fascinating area to take to take some steps towards getting accreditation. And you'd be surprised about how much you probably already know, but how much there is to learn. And for me, it just seemed a really attractive area of medicine, slightly different, and one in which I had several years immersed, if you'll excuse the pun, in that world, and it's something I've tried to take with me wherever I've gone, so there's lots of resources out there, and if anybody's interested, to just get in touch, and I can point them in the right direction for training courses.
Brilliant. We'll get Kent's contact details at the end, but useful to mention that World Extreme Medicine, we do run a dive medicine course in Florida at the Aquarius Reef Base. So if you're interested, check out the World Extreme Medicine website for more details about that. Let's talk for a moment, Kent, about the remote and offshore world. So this is kind of like the oil and gas industry, where we've got workers that are going to be on a rig or a platform somewhere out in the North Sea, or even more remote. Are there any key considerations, or could you give us any example case studies of the kind of medical conditions that have come out of your screening, and any particular dilemmas that you've had in ascertaining their fitness for that kind of work?
Yeah, so I undertook the Oil and Gas UK training that is now happily delivered online. I did that last summer, late last summer, in order to provide a means of assessing again our research divers who go on liveaboard vessels in order to do their research. And although oil and gas is essentially a means by which one can apply standards to people working in the oil and gas fields, it was the only offshore type medical standard, that civilian standard, that I felt was appropriate for the type of environment our research divers were going to work in. And just to give you an example of some of the areas that were of particular concern to me, were once one has assessed one's suitability to dive and everything that goes with the diving medicine side of things, one has to think really about how is this person going to manage in the remote maritime environment. And simple things like food allergies, let's take that for instance. Somebody with a food allergy, or a history of a food allergy that hasn't been properly assessed, didn't really understand the potential implications of that, and the dangerous situation that could arise should there be uncontrolled consumption or consumption of foods whose provenance you may not, the ingredients of which you may not entirely be sure of, and mitigating that with assessment of a need for immediate medical management, whether it required an EpiPen or whether oral antihistamines were going to be sufficient. Just trying to understand all of that, and not just in the doctor client relationship, patient relationship that we have in occupational medicine, but also just trying to look a little bit beyond that. And occupational medicine is about the individual, but it's also about the employer, and trying to help the employer help themselves do the right thing in terms of looking for solid means of extraction in terms of medical extraction as necessary. And so these all present certain challenges which, given the maritime environment, you could be a day or two away from the nearest secondary care facility or even primary care facility. These are things that one needs to consider. Simple and generally not much of an issue if there's a good if there's a solid diagnosis and there's a solid treatment plan, and people around you know what to do, and the organization knows how to deal with those type of emergencies. And you can map that situation to really any situation in a remote environment. What's your plan when things when things go wrong, and it's prior preparation will prevent disasters, or at least will make the disaster less likely.
So taking your great example there, Ken, of say you've got an individual with a history of true anaphylaxis to peanuts, and you're sending them off to an environment, a remote maritime environment where they're at least a day or two from definitive care. What you're saying is that it's not a frank no, you're not eligible for employment in this role. Is it much more nuanced than that, whereby you're really able to modify that risk as much as possible to make that acceptable, and that's in consultation with that individual, but also with the employer and the environment and what's available? Have I understood that correctly?
Yeah, no, you have, absolutely. And a key part of all medical contingency plans is understanding. It's a risk assessment, so understanding or identifying the hazard and calculating the risk, identifying who may be at risk and why, and then what is your plan? What can you do about it, and what can you do to drive down the risk? Recording it and then revisiting it. Just the classic risk assessment cycle, which is so important to every medical plan. And as you say, it is nuanced. And thinking of the situation that we faced with the individual with a history of anaphylaxis was it truly anaphylactic? Where is the specialist input? And sometimes you can be seen as the bad guy, but really what you're doing is protecting the individual and protecting the organization, in that order, I would always say, or at least trying to, and not being able to back yourself, I think, is a really important skill. Occupational medicine, expedition medicine can be a lonely task when you're the only person making these pretty punchy calls. But make no apology, because really, what you are doing your job. You are introducing a quality, or you're seeing through a quality agenda. But always be as flexible as you can be, but have your red lines.
I know exactly how that feels when you feel very exposed in your decision making. It really, the buck stops with you, and there's all these different moving parts, all these different conversations happening around you, and the people turn to you and they say, well, "What are we going to do?" And you've just got to make a decision and move things forwards. And I really like the way, certainly the expedition world, the risk assessments that I've been part of. I really like the way that you described there about there being two components to that, both a proactive component to that, where you're anticipating what the risks might be and how you can prevent those things happening in the first place, and also a reactive component. So what do you do if this happens? You've got a plan in place, you've got the right equipment, you've got the right training, etc., so that mitigates any sequelae from that event were it to happen. So is that how you see things? So kind of in a risk assessment, a proactive and then a reactive component, so those kind of separate strands?
Yeah, absolutely. And I think one of the roles of occupational medicine, being the specialty associated with the workplace in whatever format that happens to be, is helping those doing the risk assessments, which are to be done well. They're a tricky thing, and just helping the leaders of expeditions, those companies responsible for delivering these risk assessments, which can change over time, helping them make sense of this hazard. What are the potential medical sequelae from being exposed to noise or extreme heat, extreme cold? What are you looking for? What are you trying to prevent? And one of the key messages that I try and get across is, if you ask the right questions, you're going to get the right answers, and it's helping organizations know what questions they need to ask, and not just going off a picking list, not just trying to be too formulaic about things. Understand what it is, why you're doing this. Understand the risks. They will be most the best people to identify the hazards, but could also do with help in identifying unseen hazards or hazards that haven't been thought about particularly, and then calculating the risk, and then making sense of that, of the matrix of hazard and risk, and coming up with a set of priorities, and understanding that sometimes you cannot reduce the risk beyond what is straightforward, and to a large degree that is risk is part and parcel of some of these more testing expeditions, more testing environments. And great, that's how it should be, but it's understanding that risk and doing everything that you can to drive down that risk, to make sure that through your preparation, your mitigation, your professional understanding of the environment that you're working in, is going to make a success of everything. And it needn't be obstructive. It's facilitative, and it is trying to optimize your stated objectives, whatever they might be. And this is particularly true, I think, of situations where there may not be immediate access to professional medical or health support. And there are many expeditions who don't, for one reason or another, have a professional medic working alongside them. So it's in those situations where identifying the hazards, just going through the risk process, the assessment process, is so key, and dealing with uncertainty, dealing with the lack of evidence in some areas is also something that we really need to or that occupational health can really help with, and that that's the thing that excites me. That's the thing where I think working alongside supporting expedition medics, because they are the people who are going to be dealing with this in the field, supporting in the pre phase, being in there in the background during the expedition, and really helping in the post phase, thinking about things that may not have been thought about before, optimizing. I've used that word probably far too many times in this last half an hour or so, but that's what it's about. It's optimization of people and the situation and what you can gain from it. And I think OCMed, with the particular skills that we are used to dealing with on a day-to-day basis, has a lot to add.
I think that's a huge reframe for me, Kent, this idea of you being that word optimization and being facilitative and not obstructive, not being the policeman, not being the bad guy, being a barrier to entry for some of these incredible experiences that our clients and participants want to be part of. Nevertheless, I think that there's a huge perception of us medics that do kind of pre-deployment medicals, that we are going to put the brakes on long-held ambitions and dreams. And there's this huge issue, something that I've experienced. I'm interested to hear your experience and views on this, of the issue of non-disclosure, where people just don't quite give you the full picture, or they perhaps try and brush things under the carpet or downplay certain aspects of their medical history that only really come to light later down the line, actually on the trip itself, when it's too late to really do anything about it. Tell us a bit about your experience of non-disclosure in expeditions and other extreme environments.
Well, it's such an important point to raise. Well, I think the fact that to start off with, we have to accept that it's always going to be like that, and it is something that we have to deal with. I think it's all to do with understanding why are we asking these questions, and what is the purpose of this. And I think if people understand, if you're separating out the occupational medicine and the primary and the expedition medicine, then if you are able to impress upon somebody why we need to know this, it may be relevant, it may not be relevant, but be safe telling us this information, then we can make sense of, we hopefully will be able to encourage that individual to share that information, and we can turn that into a function. We can look at the functionality, and that's what it's all about. Are you able to function in this environment? Is it safe for you to function in this environment? And then you're always going to have situations where people will still not disclose. But I think given the that we often come across this in occupational medicine, I think it is something that we may be able to help expedition medics tease out and explain why we need to know this, and turn medical histories into functional capabilities on the ground, and try and impress upon people that actually this is not always something to be worried about. Screen people in, but accept at the same time that sometimes it is not a good thing for you to do this, and explain the reasons why.
Because the standard capture tool, the screening tool that's used across the board, is the health questionnaire, isn't it? And it's so easy to, it's a lot, very much a box ticking exercise. Do you have history of epilepsy, heart disease, high blood pressure, etc.? So easy to just not tick the correct box, or just not. Is there a better way, do you think, that we could pick up on some really important medical comorbidities than the health questionnaire? Is that still fit for purpose in this modern age, or is that just the way things need to be done?
I mean, if you take an off-the-shelf medical questionnaire, there will be questions in there which are probably completely irrelevant. Why do you need to know if Okay, let me think of a question here. In some medical questionnaires that I've come across in the past have asked, what color are your eyes? Or I can't see that that's of any relevance at all. Or will ask questions that people don't quite understand. So they will ask questions that the medical professionals will understand, but others may not. So, for instance, have you ever had, any very dark coloured stools, and leave it at that? What people need to understand the rationale for these questions, and one can take a lesson from pre-employment questionnaires where safety may not be, or safety critical functionality may not be a particular interest, and you just have to ask, are you ask questions that are specific and justifiable, and there is a lot of legal precedent in this area, but we're generally talking about people who are not going to be employed on an expedition. Although, of course, the expedition, there will be some people employed on that expedition, no doubt. So, yeah, what? Don't ask a question if you don't know what to do with the answer. B, try and ask questions for which there are standards, and if there aren't standards, then there have to be other good reasons for asking that question, or a body of consensus. And if there is neither of those things, well, then the utility of that question is probably of very little. Is very little. Yeah. So having the right experience, having the right training, knowing the environment, will help you make sense of the fitness assessments, and that's where I think the medics who are involved in expedition medicine will over time develop a huge bank of knowledge. But there's always something, I think, we're always learning, aren't we? Lifelong learning. And there's always something, a different angle, a different approach, a different formula that you can apply from occupational medicine that helps you tease out the salient issues. Ask questions for a reason, be able to do something with the answers, map the individual to the task, or the task to the individual, if that's possible. Sometimes it isn't, except that there are, irreducible minima in terms of what you can do, and there's always going to be a degree of risk. But everybody understanding their role, everybody understanding what they're getting into, and having faith and trust in the people who are assessing them, I think is a really key role. And this, as I said before, is where occupational medicine can support, not supplant, the expedition medicine professionals, people who are deploying. And I see that as a very happy marriage. And I'm sure there are many, occupational medicine physicians with experience, or I have to say, many, in fact, probably every military primary care physician of whatever flavor, Army, Navy, or the Air Force, will have a deep understanding of occupational medicine aspects of, in the general sense or in the specialist sense. And we've spoken about diving, aviation, thermal, and so on.
Yeah, we've looked at examples of asthma as a pre-existing condition, of anaphylaxis. What about mental health? Someone with a previous history of psychosis or depressive disorder. What role do you think that plays in someone's fitness for an extreme environment? How much risk does that confer, and how do you mitigate that kind of background on a pre-deployment screening?
Okay, so I mean, again, that's a huge issue, and mental health we're lucky to get to go through our lives without having some, as is all of us, without having some brush with significant mental health issues. And let's accept that is just the way it is. And but we're getting much better at recognizing and dealing with it. But it all goes down to why does one need to know what are the issues, and this is where occupational medicine at the nexus of all the specialties can draw in specialist reports and make sense of those reports, mapping the individual and their condition or their past condition to the environment. And often we find, and I was just reading in BS 8848 or a summary of it, that often one expedition medics write to GPs or to specialists, whether it's psychiatrists or surgeons, or and ask them whether or not they feel an individual is fit for this expedition or this role. But it does recognize that they may not be the best people to give this advice. And certainly when I was in the military, we had real challenges sometimes in managing expectations of individuals who were given the all clear by a well-meaning surgical specialist, a civilian surgical specialist, or a physician, only to have to manage expectations downwards, where that functionality or lack of functionality would not suit the environment. So looking at mental health, given it would be on a case-by-case basis, and not everybody, it's not a big deal for most people. There are, of course, important and serious situations that need really careful management. But again, this is where asking the right questions and getting to the nub of the clinical situation, and again, I've said this before, screening people in rather than screening them out, but not in every situation. And it's the skill of the expedition medic or the occupational physician in helping the organization ask the right questions, and you can make sense of the risk assessment and then draw up recommendations, and it would only ever be recommendations to help the people making decisions as to whether or not this was a risk that was palatable, both for the individual, most importantly, but also then for the expedition as a whole in terms of outputs, but also to other members of the expedition for whom injury or illness can be very distressing, and can cause significant disruption, which if it's avoidable, then that's something that should be carefully considered.
So you mentioned the BS 8848 standards there, Kent. For the listeners that haven't come across this before, this was a set of industry standards agreed back in 2007 for operators of adventurous activities to adhere to, and they could they could sign up to these standards, and it benchmarks the degree of safety, a degree of prior planning and preparation. So useful to look out for if you're involved in any organizations, if they've got BS 8848 accreditation. Interestingly, it's called 8848 because that's the height of Everest, or was. Everest has since grown by 1 meter. I believe it's now 8849 meters. So maybe they need an update.
I'm out of today.
So yeah, Ken, we've focused on this episode very much about the individuals, their medical conditions, the conversation that we have pre-departure, but your role as an occupational health physician is much more holistic than that, and you're involved often throughout that individual's journey, both during deployment and also afterwards. And there's a great phrase from the Army from the military, which says join well, train well, live well, work well, and leave well, which is a nod to that very kind of holistic approach. Can you just tell us what that means to you?
Well, this was those phrases appeared in, I think it was the Army Health Report 2015, 2016. And all the credit goes to a public health colleague of mine who came up with that framework. And really, one can apply this to expeditions. One could apply this to people joining any type of organization. But the military was absolutely tried its level best to make sure that people joined well, and at the end of their careers they left well, and everything in between. And the joining well piece was, make sure that we select the right people. So on an expedition, you select the right people for the task. In every regard. And then training well. So make sure that people train well. In terms of being able to deliver the outputs, optimize their physical fitness, mental fitness. Get ready to hit the ground running when the expedition commences. Then there's working well, so making sure that you have all the skills and competencies necessary to deliver expedition outputs. Live well. It's not all about work. It's about living with people and enjoying the experience of the expedition. And then all good things come to an end, and it's leaving well. And it's that part that I must say, my experience with the military was that there was such an emphasis on making sure that people left in an optimal condition, both medically, in terms of employment prospects, and so on. And I think there could perhaps be greater emphasis on this in industry. People leaving organizations, people leaving expeditions. What are they going back to? Have they sustained an injury that might impact on their future employability? And if so, how do we recognize that? And what can we do to mitigate that in a timely fashion? So I'm thinking, for instance, somebody who relied on their digital dexterity for part of for their employment was exposed to non-freezing cold injury or even freezing cold injury as part of their expedition role. What are you going to do for that person? Where do you send that person? Is it within the gift, within the knowledge base of a general practitioner to know, to either diagnose or know where it is that they can go to optimize the treatment and outcomes for that individual. So part of this offboarding or this leaving well, I think the expedition guides that I've seen so far are very much pretty generic. Go and see your GP if A, B, or C happens, and if more than one or two people have A, B, and C, then everybody should be screened. I think one needs to be more targeted about this and looking at the hazards and the risks or that people have been exposed to on their expedition, and target the screening as people exit that environment. And I think we can finesse that. We can add a layer of completeness to that in some situations that hitherto may not have been given sufficient
Yeah,
attention.
I completely agree, Ken. I think a lot of energy and emphasis is placed on that pre-departure phase, and everyone's getting their kit ready and their sponsorship lined up. And but the biggest neglected area for me is that when people return, and especially if it's a longer deployment, how they then reintegrate into normal society, both in their personal and professional sense. I've been away 6 months in Central America, and I've been away to Myanmar for 6 months. Each time I remember, coming home was actually a real challenge, and I hadn't really anticipated some of the difficulties I would have, just in terms of that complete change in your routines and where you draw your energy from, and it can have a huge impact on your mood as well, can't it? And perhaps that's something you're going through now. You've just been out in Saudi Arabia for 2 years. You've just come back to Sussex. Are you feeling that a little bit yourself, that transition, that adjustment?
Well, my wife is certainly feeling that adjustment. I think she was quite happy with me being away, but But it's very true. And again, taking a leaf out of the military's book, there, tough operational tours. There was always a period of, in barrack, decompression, where people just slowly reintegrated back into, normal barrack routine. And I'm not suggesting that, should be the case in every situation, but I think it bears one needs to consider it, and particularly if it's been a tough time, or there's been tragedy, or there's been frightening situations. That there should be a comprehensive but light touch assessment. That just possibly gives people a framework, a structure to reference if they need to, but also, again, I said just before, a targeted approach. It can be very difficult to reintegrate, and people go on expeditions for all sorts of reasons, around the world, sailing, in trips, and why are people going? What is it that they hope to gain, or what is it that they are taking themselves away from, perhaps?
I've definitely seen that, where people have perhaps run away from a situation it's not gone anywhere. They've come back to it, and they're finally having to face up to it.
Absolutely, and it's an opportunity as well to identify in a non-intrusive way. And I think OCMED, this is what we do. Is just asking, in terms of the occupational environment, as opposed to what GPs are excellent at, what physicians are. It's asking the right questions of that individual to try and tease out specific conditions or situations that one can address early, and timeliness is really important. I recall, as a sort of slight segue here, when I was a junior doctor, we used to operate. I helped very sort of peripherally in what we call the FIPO clinics, the Far Eastern Prisoner of War clinics, and we saw guys come back from places like Burma, as it was called then, from places in the Far East where they were incarcerated during the Second War, and had suffered a lifetime of ill effects, simply because either at the time there weren't the means to screen, or there weren't the means to identify or even recognize that the long-term effects of some of the conditions that they contracted when they were out there. And it just struck me that there was a huge benefit for a good number of the FIPOs, wonderful, long-suffering by definition group, and some had absolutely, nothing to identify, but there were a good number of people who met with benefit from attending these clinics. And screening has to you don't screen for any reason, there have to be certain criteria met. I won't go into all of those. I'm not sure I can remember all of those, but there is a value to all of this. And I think the post expedition phase is an opportunity. It certainly isn't a threat. Nobody should regard it as a threat. But I think it is something that perhaps we could brush up a little bit on.
Well, Kent, I've learned a huge amount from talking to you. Thank you so much for your time today.
Thank you.
I think the big things I've taken away, this idea of asking the right questions is so important, isn't it? And being comfortable with uncertainty and risk. It is never a black and white answer. I think as medics, we're in a great place to deal with that, the nuance that comes with this kind of work.
Yeah.
And of course, the seven golden P's that you've alluded to, it's prior preparation prevents piss poor performance, all of that, that just is really key in this whole game, isn't it?
Yeah, absolutely. It's all in the preparation, and the more time you spend with that, the easier time you can expect, more time to focus on the fun things.
Yeah, that's right. That's it. And we're enablers, we're facilitators. We're not policemen. That's a key message as well. So thanks so much, Kent, for your time today. Don't forget, everyone, the World Extreme Medicine Conference is happening on the 13th to the 15th of November this year. Tickets are flying off the shelves like hotcakes, so make sure you get yours soon. If you want to hear lots more content like this, lots more guests like Kent from today, who've worked in expedition, military, disaster, humanitarian, space, aviation, from across the board, that's the place to be this November at Dynamic Earth in Edinburgh or online. So big final thank you to Kent. If you want to reach out to him, the place to go is LinkedIn. He's very active on there. You can ping him a message and he'd be more than happy to chat to you. So thank you, Kent.
My pleasure.
Thank you to those of you listening. Stay extreme.